I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I would like to welcome everybody to a new episode of Tell Me Where It Hurts. Today's episode is going to be centered around nursing. Yesterday was Florence Nightingale's birthday, and it was the International Day of Nursing. So today we have a special guest that has a lot of experience in health IT, nursing IT, as well as just plain nursing and nursing interactions. Before I get into that, I'd like to start out with a little story. When I was an intern in about a 300-bed hospital, I was the only person on the wards that would take care of the teaching service. So I would start out that first day. I had my lab coat just packed with index cards, the Washington manual. I had a reflex hammer, my stethoscope, tongue depressors. I mean, I looked like a walking supply for medical things. So as I thought I knew everything I needed to know, I found out very quickly I didn't. One of the first people I ran into was the head evening shift nurse, and I'll remember her forever. Her name was Judy Sinclair. Judy had about 25 years of experience. She knew a tremendous amount of medicine other than just the nursing aspect, but actually real medicine. She was one of those nurses that could treat patients without having an MD if she really had to, I think. But one of the things that Judy taught me very, very early is that nursing is a collaboration with the care team, including the physician. And I learned that very, very quickly. I remember heading down the hall to my first code as an intern, and Judy was right beside me, and she bent over and said, "Dr. Anders, we're going to get through this. Just calm down. You know what to do." And by George, we did. Patient survived and was transferred to the ICU and then recovered. So nursing, to me, has always had that special collaboration feeling about it. As a matter of fact, I was probably one of the only physicians in my multi-specialty group practice that actually read the nursing notes before I actually saw my patients. Because if I really wanted to know what was going on with those patients, I would read the nursing notes, because the nurse would know. And even better if I could talk to her or him before I would go and see them, because they weren't in the hospital for me to take care of them. They were in the hospital for nursing to take care of them. Like I said, this particular episode is all about nursing. It's going to be focused on that and the collaboration that nursing provides medical care. And to that end, our guest today is Charles Boicey, the Chief Innovation Officer of Clearsense, a healthcare data platform company based in Jacksonville, Florida. Additionally, Charles is an assistant clinical professor at Stony Brook University, where he developed and teaches the analytics elective concentration. Charles is a former president of the American Nursing Informatics Association. So welcome, Charles, to our podcast today.
All right, Jay, thank you so much. And thank you for the collegial story you told from a physician's perspective in nursing. And we absolutely feel the same way. So thank you for that. Although we're kind of dating ourselves, a lot has changed since we both got into healthcare in the late 80s. And we have definitely progressed to a more, collegial environment between physicians and nurses. And then one other, fun fact about, Florence Nightingale. And, yes, we all look up to her from a nursing perspective, but as a nurse informaticist, even more so. As you know, she's responsible for what she called the Rose diagram, a data visualization of data over time that ended up being what we call now, a circular histogram, which is used, quite frequently in healthcare. And then the other fun fact, very few people are aware that she's inducted in both the British as well as the American Society of Statistics, which is a really, really big thing. She did a lot of work in stats. And again, as a nurse informaticist, and, yesterday being her birthday and, kind of nursing informatics day, definitely the right time for this conversation.
Well, thanks for being with us today. I think it's going to be a fun conversation. I'd like to start out a little bit about burnout. with the pandemic being what it is and the really hard working conditions that all clinicians have, nursing physicians, everyone that's caring for these patients, a lot of people are talking about physician burnout and especially nurse burnout. So like to talk a little bit about EHR usability, because that's been one of my kind of focuses, and how that is contributing to, or what could we do about it to make it easier for nurses to do what they do and try to eliminate that burden.
No, that's a good topic to start off with. Now, from a burnout perspective, and if you think about it, in the last 14 months, how many new entrants to practice have there been, both from a nursing side as well as a physician side? So, you and I never experienced having to, gown up, glove up, and mask up for an entire shift. And some of those 12-hour shifts extended into 16 hours now, or even beyond in many cases. So that, repeatedly, day after day, week after week, and now month after month, absolutely has had a toll on providers. And then exacerbate that with, the EHR. And I'll use another quote from, Florence. And, she said, and I'm going to paraphrase it, if you must document, but if you do document, only document that which is pertinent and which is related to patient care. And I think that we'll get into the usability, aspects in a second, but think about from a nursing side, all of the things that are being documented because let's say, the quality people wanted you to document this, and maybe compliance wanted you to document that. And then somebody in leadership wanted you to document, and it just, you've got all these, siloed, type of, inputs and whatnot. And what do the teams do from a config perspective? They go ahead and do that. And then on the nursing side, oh my God, you've got a mismatch of all kinds of stuff. And, if you're thinking about what we've had to do for the last 14 months, if you went back and took a look at documentation, how much of it actually got done. So I think that, outside of, design, which we'll get to in a second, we really got to think about what we are documenting. And, I always, had my mantra was document, what is clinically pertinent as well as what is, regulatory pertinent. And that's it. If you're collecting, survey information, figure out another way to do that. And I really, always kind of, held the line there. Now from a usability perspective, and we're not going to, name names here, but if you think about these systems that we've been using, they really have, from a front end perspective, they really don't have the architecture and to support, what we would really call, usable, environments and so forth. So that's kind of where we're, limited. And, the EMR vendors are absolutely doing the best that they can. We're doing the best that we can to, minimize that which needs to be documented. But our real super constraint here is the environment by which these user experiences and user interfaces can be coded in. And that really is a big burden.
One of the things that I have seen on the physician side, especially, but it's right there at nursing as well, is that nursing is not involved with the design of these systems and what really can augment what they do in their workflows. You're exactly right. A lot of things are scattered all over, and you have to document this for one purpose and that for another, when really sometimes it's the same thing. So by doing your nursing practice, you should be able to cover most of all of those things. What's your opinion on how more we should be involved in the actual design of these systems and how they do what they do in their workflow?
Sure. So that's an absolute necessity, and it has to be in a focused environment. We tend to rush, right? We tend to, try to get things done as quickly as we can. And we very seldom get time to just, think about what we're doing and really, contemplate and focus on, what is the best approach? How can we put our, workflow into the EMR in the best way possible? It's more like, some deadline has been put in the ground and we're rushing to it. So take that away, and to answer your question, a little bit more specifically, yes, nursing should be at the table, but nursing should be at the table at the basic levels as well as the hierarchical levels. So look at, I'm not going to say, that I'm going to be the best person in the room. I'd be the best person in the room to help guide the conversation, but I need the folks that have been on the job for 3 months, for a year, for 2 to 5 years, 10 years. I need all those people in the room with the understanding and the intention that we're here to make this the best experience as possible. And I don't have 30 minutes because I got to run back to, take care of a patient, right? Yeah. That's the environment that we really need to, do this, thoughtfully. And, right now we call it optimization, right? But optimization really means that we didn't quite get everything right when we went live. Then we're now going back and we're trying to, try to get it right and so forth. So I think there's an excellent opportunity for us to, be very thoughtful and diligent in this optimization, and it's going to go on forever. It really is. But again, kind of going back to, what we talked about previously, document what really needs to be in there from a workflow perspective, and do the best you can with the constraints. We have constraints, functionally on what can go into that user interface and how those, designs can be, how we can do the design work. But if clinically we understand those limitations and we can push them to the max or have a basic understanding, then we can do the best we can in those environments. And that's really kind of what we have to, push toward. But it really takes, an effort, and it takes a commitment for those that are doing this type of work to thoroughly understand the work that they're designing in, so they can translate that workflow into the environment.
Now, we're both clinical informaticists after being clinical people to begin with, and being into clinical data. One of the things I see a lot in EMRs as a whole is they never give much back to the provider that's actually using them. It's a one-way street. Things go in and they go into that black hole, and then you try to find whatever you put in that black hole. But it shouldn't be like that, I believe. But in terms of data, what do you think should be the focus of that clinical data that the nurse puts in? And how should that be returned to them to actually help them do what they're doing?
Sure. That's an excellent question. And let's go back to, how these clinical systems evolved and what they evolved from. They evolved from financial and scheduling systems, primarily, financial systems. So the goal of all of this is to drop a proper bill, correct? Do you agree with that?
Absolutely. They're all billing systems, whether it's in a hospital or a clinic. The hospital is collecting RVUs for a hospital bill. So the initial intent might have been appropriate at the time, but going forward, not so much. So a lot of the work that I do, Jay, that I think is relevant, to your question, is what can these systems do for me as a nurse? And I'll take it to at the basic level. If you think about certain patients, classifications of patients from a demographic perspective, from a diagnosis perspective, from a treatment plan perspective, we've got a lot of knowledge in those EMRs in the data in the back end. So that really should project and help guide us through patient care. And what I call it, Jay, is I call it a situational awareness, understanding a little bit about the patient over the near past, what's going on now, and what's likely to occur in the near future. So if you look in a high acuity environment, then I have a pretty good, from a machine perspective, from a data perspective, have a really good idea of what's happened with this patient over the last 3 hours, what's occurring now, any subtle type changes. And then based on what is known as nearest neighbor modeling, I have a whole database, if you will, of patients like this that can help guide nursing and other clinicians through what should I be looking for, what are the possible conditions that what can be occurring in the near future. So if I have somebody that's progressively changing physiology, but it's so
minute that I can't, perceive it as a human being, but the machines can do it, then I can, hey, you really kind of need to check your, levels of titration, or, there might be some, volume loss here, just some helpful hints and whatnot. And then from quality measures, we always talk about retrospective quality measure reporting. This data is also pertinent for helping us understand where a patient is at any given time for meeting quality measures.
Oh, absolutely. I've always been a proponent of let clinicians practice medicine, nursing, physicians, whatever, and let the machine work out what needs to be recorded for all the quality measures and other things, with appropriate reminders from time to time to make sure that happens, because we're not perfect. We need to be reminded, but it's not the first thing that you're thinking about when you're caring for patients. It's a secondary or even a tertiary consideration to make sure you've done all of that. Now, you're the Chief Innovation Officer of Clearsense, and it's a data confidence company from what I read. Would you like to talk a little bit about that and what you're trying to do with clinical data and trying to get good data to do something and solve that garbage in problem?
Yeah, sure. So, I'll talk a little bit about, from a practical perspective, we won't get deep into the technology and so forth, but if you take a look at, many of our, systems in healthcare, whether they be the electronic medical record or financial or other clinical systems, we have, issues in data quality. So just bringing, data across and then, doing analytics on it, whether it be, quality reporting, forecasting, or even, real-time, running, machine learning or algorithms against it, is somewhat flawed, because we need to take that data from its, source system, get it into a raw state, if you will, so we can understand the underlying, deficiencies, so then we can then enrich it to a, curated state, if you will. And what does that look like? And you deal with this all the time. I bring, data in and it's ontologically incorrect. So I have to do ontological right sizing, because, way back when we were rushing through all of this, Loing, SNOMED, CT, RX norm, the ICDs and others weren't, that well paid attention to. And yes, the coding may be correct in the ICD, but we allowed, free texting from a problem list. So it's, it's a little bit of a, pain in the neck, if you will. And there's a lot of, null values, inconsistent values, and things of that sort. So a lot of the work that we do from a machine learning perspective is the ability to, right size those ontologies to, correct those, deficiencies, so that we can get it into a, curated state, if you will, so that it's usable. In addition to that, healthcare is very domain specific. So if you're able to, understand, patient domain, provider domain, and you're able to get that data to the point where it's, trusted and usable by all, from a domain perspective, then, the quality people can use it. Provider systems, this very well. Large healthcare organization, may have, 100 provider systems, and none of that data is correct. And if we take it back from a nursing perspective, just understanding, various patients by, classification and how best to provide nursing care going forward, it's important that, we've classified those patients correctly, and then we're providing, the proper information at the proper time, because the underlying data is correct. And it's not so much in the natural state of the electronic medical record, unfortunately.
And that will speak to the giving something back to the person actually using the system. If you have good data in, you can actually present data back at the point of care that would actually assist somebody, as opposed to multiple mistakes or mismatches in data that will give a very confusing picture if presented back without some type of massaging and filtering and trying to put things together that a clinician actually will put together in their mind when they're doing what they do.
Yep. And, I call it, and you said the word properly, I call it intelligent assist. Most folks talk about artificial intelligence, but how can we use machine learning and other, advanced technologies to actually assist in patient care? not be prescriptive where we're telling them what to do, but we are providing, information that, produces a cognitive trigger that allows both, nursing as well as, physician staff to make some decisions. So if you think about, early sepsis, which is really important for all of us, regardless of, our profession, inclusive of the family. And we know that progression of sepsis is nonlinear. It's a hockey stick. The earliest we can detect, the earliest we can get, and all that data that we're putting in to these systems, has. And I'm not talking about filling out a Muse checklist or whatnot. I'm not talking about some rules-based system where we're waiting for the last piece of data to be checked off before we raise our hand and wave the the sepsis flag. There's other things that are contributory towards sepsis that are in our EMRs. So by collating all of that and presenting it to a clinician saying, hey, look at over the last 3 hours, physiologically these things have occurred. And oh, by the way, from a lab perspective, guess what? Your ABC count, your white blood count is kind of coming off the chart. But we as human beings can't be in the chart waiting for that blood value to come back. We can't do it. But a machine sure as hell can, and collate it and actually present it back so that we can say, hey, this patient is going to enter a sepsis pathway, or no, they're not, and then make the necessary adjustments. So we have the underlying data. We just have to get this information back. Or at the point of discharge, hey, look, from a social determinants and from this patient's demographic, and most patients like this patient needs to go to a skilled nursing facility or rehab, or you better make sure that the patient's family is around them, because we're going to have a little bit of trouble getting this patient to adhere to discharge instructions. And oh, by the way, you better get those meds and you better give them back, because guess what? They don't have transportation, and CVS or Walgreens is pretty far away, and they're likely to just come right off the radar. So those types of data points are in our EMR. We just need to get that out to the clinicians at the proper time in their workflow.
That's a very, very good point. Very good point. I'd like to switch gears just a little bit here and talk about the 21st Century Cures Act and the Open Notes Initiative, which I am absolutely foursquare for. As a clinician, I'm a little apprehensive about how that will be implemented. They're going to start enforcing data blocking rules, so we'll be able to share information as we should have all along. And that's been one of the problems with the pandemic, is the fact that we have not been able to share valuable, accurate information about who has what and how many people are hospitalized and things like that. When I see the CDC getting information on a flat file about these things, it just kind of scares me just a little bit. Hopkins had much better data in what they were doing. But that's going to be augmenting things like care planning and medical management needs and things like that. What's your take on the Open Notes Initiative and how that's going to assist or detract from patient care?
Sure. So, most folks probably on the line know what Open Notes is. If you don't mind giving just a really quick, either you can do it or I can do it, but I'll let you do it. And then we'll continue the discussion, because I want to make sure that as we go through that the folks are familiar with Open Notes.
Well, as a really brief definition of Open Notes, this is the requirement that patients have unfettered, unfiltered access to all of their medical information that is stored in electronic healthcare. The couple of issues with that is that it's stored in multiple different places, so getting a complete picture might not be able to be done simply because we're not sharing it. But essentially, that's what it is. Patients have the ability to go in and look at all of their medical information. In addition to that, there are rules in place to allow or to prevent blocking of that information being transmitted, both between institutions and from institutions to a patient.
Excellent. And I think that the other part of this that needs some discussion is there's a feedback loop from the patient's perspective, correct?
Correct.
And that's something we're totally unprepared for.
Absolutely.
So if I look at my medical record and I don't agree with, whether it be, nursing notes or physician notes or the surgical, report isn't me, or anything of the above, or I didn't say that in that clinic visit, I have the opportunity to append that. And, how is that going to, happen? And so that's number one. Number two is, I know that we've made some, excellent advances from an interoperability perspective. But thank you that regulatory wise, that's going to be forced and totally forced upon us, and it needed to be forced upon us. Once that's in place, then I think the information from payer to provider, from provider to provider, and so forth will be better served, and from the perspective to the patient as well. And if you think about records incompleteness, we have various interface standards, FHIR, et cetera, not quite developed out to transmit the entire record. How do we transmit an entire record now? I'm kind of smiling as we put it in paper form, in PDF form, and send it off, right? We send it off to some type of file transfer that isn't machine readable. It is human readable, and the best we can do is put that in our document storage and hope that the receiving provider actually has the time to open it up and roll and scroll to the point that's that's pertinent. So, do I have a magic bullet to this? No, I don't. But we better get this thing figured out, and we better get it figured out real quick. I'm very grateful, and I'm very happy to see the feedback loop from the patient back to the healthcare provider. I think that it's really important that that is in place. And what we didn't talk about is how do we assist the patients in understanding what the heck is in that record that they're looking at. Where's the data dictionary for them to the terminology? Where's their reference? And how do we help them understand our jargon, if you will, our terminology, and how do we put that all in layman's terms?
Yeah, I think Google's going to get a workout when patients start reading these things. They're going to be searching for what does that mean, and why is this value? It's abnormal, but really for me, it's not abnormal. And what does that mean for me? So there's that whole cadre of having to translate that into pure patient ease so they can understand it. And I think there's going to be a lot of back and forth before we ever get this worked out. But I absolutely believe that patients need to read their medical records because, as we all know, me included, there were things included in my medical record that were incorrect. So you had to go back and correct them. And I think that's a great idea.
And I think if, and we have to talk about this, from a uniformity perspective as well, where, hospitals differ even within the various IDNs, correct? Mm-hmm. But if we are able to universally put in place documentation that is universal and is coded with all the various ontologies, then we've, kind of succeeded in putting together, a platform of data, if you will, that is transmittable and is interoperable. And that's kind of one of our failing points, currently. Yes, we can do labs. Yes, we can do meds because of LOINC and RX norm and so forth. But not every healthcare organization has the wherewithal and has done the work to properly codify nursing notes, codify clinician notes from a H&P perspective, all the way to consults, clinical, and so forth. And that really is an effort that needs to happen to make this truly interoperable. And then from a patient perspective, to make it digestible on their side as well, because then they'd have the opportunity to look up terms that they're not familiar with.
Well, we're kind of running out of time, so I want to ask you. I ask this question of all my guests: if there were one thing in nursing IT or healthcare IT that you could change, so you're now king for a day and you've got one thing you can change and everybody's going to follow it, what would it be?
It would be for me and my colleagues, both from whatever the discipline may be, whether it's medical, nursing, our colleagues in pharma and whatnot, is to be able to have the same experience that we experience with our apps on our phones, apps on our tablets, even applications that we use that are web-based in the electronic medical record and electronic health record. We are constrained by certain technologies that don't allow us to have that experience and usability that we really need. And I'm going to ask for two. That's one of them. And the second one is the elimination of nuisance alarms, whether they're generated within the EMR or whether they're generated from devices and whatnot that we work with on a daily basis, and that were placed there for purposes of legal avoidance as opposed to what's actually needed to do our work. And I think I'll kind of leave it at that.
That was a very good answer, and I'll give you two. That's okay. It's kind of hard to come up with one. It's not a really easy question. So, Charles, if someone wants to get a hold of you at Clearsense, how would they do that if they want to know more of what you do and how you do what you do?
Sure. Absolutely. Check us out at clearsense.com or contact me directly at C Boicey, so CBOICEY at clearsense.com, or charles.boicey at stonybrook.edu.
Charles, thank you so much for being with us today. It's been a great conversation.
All right. Thanks, Jay. I really appreciate hanging out with you. And it seemed like this went in 3 minutes. So
it's very
fun.
quick.
Thank you.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.